And today we're going to present on opioid use disorder treatment and barriers. This is a slide presentation by Dr. Bott, who is on a much deserved leave this week. So I'll be filling in for him and Dr. Lindsay. The objectives are to summarize the key findings of reporting on the national opioid overdose epidemic and describe how they inform clinical practice, to list the recommended treatment options and other treatment modalities that are part of medication for opioid use disorder, and to identify the barriers to treating opioid use disorder in personal clinical practice. So let's talk about the epidemiology of this epidemic. So this is a slide that I think you have seen in other presentations, but it summarizes well the three waves of the rise in opioid overdose deaths. And so what you see here, again, this is the years presented here from 1999 to 2018. And in the beginning, we have wave one, which is represented by this purple line that shows the rise in prescription opioid overdose deaths. But that starts to plateau with the changes in prescription practices around 2010. But what we see there is the second wave, which is a rise in heroin overdose deaths, which occurred in part when people were no longer taking the prescription and they would turn to heroin as an alternative. And then wave three, starting in 2013, is when we see this rise in synthetic opioid overdose deaths, namely fentanyl and carfentanil, so not methadone. This is rising, as we know, still past what we see on this slide. So the number of drug overdose deaths decreased by 4% from 2017 to 2018, but the number of drug overdose deaths was still 4 times higher than in 2018 than in 1999, as we saw on that slide. Nearly 70% of the 67,000 deaths in 2018 involved an opioid. And from 2017 to 2018, there were significant changes as detailed here in opioid-involved death rates. So we saw a decrease by 2%, however, and a prescription opioid-involved death rate decreased by 13.5%. Then we saw the heroin death rates decrease by 4%, but we saw, again, the synthetic opioid-involved death rates increase by 10%, excluding methadone. What did the New Mexico data show? The most common drugs causing unintentional overdose deaths have been prescription opioids, and then closely followed by heroin, and then methamphetamine, benzodiazepine, and cocaine. And I think that this data here doesn't include what we're seeing currently with fentanyl, but we in practice have seen a huge rise in unintentional overdose as a result of fentanyl. Here you can see a chart by drug class in New Mexico from 2012 to 2018. Again, this doesn't capture the most recent data, but just to again show the death rates due to these different substances. And here you can see the intersection of methamphetamine, which when Dr. Warwick joins us later, he could certainly elaborate on this more too. What they see in the emergency room is significant increases in that. And then certainly in terms of fentanyl on the rise, this again would be increasing after 2018 as well. And then what are the opioid overdose related emergency visits in New Mexico from 2014 to 2018? We saw that steep rise initially and then a plateau and a slight decrease. Again, this information here is ending in 2018. So what are the adverse outcomes associated with opioid use disorder? So the natural course of this disease involves medical risks. Certainly hepatitis C is a large one. And this is national data that looks at 70% of people who inject drugs will contract hepatitis C. 65% after 1 year of using, however, that rises to about 85% after 5 years. And then HIV, we don't see as much with injection drug use in New Mexico, but nationally of people who inject drugs, about 25% of this accounts for about 25% of new HIV infections. The mortality risks are huge. So there's an overdose risk of 1.5% per year. A 24-year study showed that 28% of the sample population had deceased. The 30-year study in California showed about a 50% mortality in over time of that population that was studied. So the annual risk of dying for someone who is using heroin is increased up to 20 times that of someone who doesn't use. And then this is even more shocking, that when someone is not in treatment, there's a 63 times expected mortality rate. So again, leading at the causes of accidental death are drug overdose, and then suicide, violence, accidents, infection, chronic disease. So these are all tied into someone's, sorry about that, substance use disorder. There's also psychosocial risks of low employment. So 36% of active people who are actively using were employed. This is really difficult when you are injecting something that is has a short half-life, such as heroin. It needs to be dosed in order to not feel the effects of withdrawal every 6 hours. People need time to recover. So whether feeling sick from withdrawal or needing to be excused to use, it's very hard to hold on to a job. Crime is high. People, in terms of supporting ongoing use, there's increased crime. And so a study at 10 years showed about 18% of individuals were incarcerated. And one study showed over a 12-month period, at least 80,000 crimes reported. And then the costs, medical costs and costs in total to society at 20 billion per year. So huge costs. I'm going to turn the presentation now over to you, Dr. Lindsay. And you want me to stop share, or what would you like to do?
Yeah, because it's a number of slides, so I'm happy to just transition.
There you go.
Get a little smoother for everybody, and then I can switch it back. Okay, so we should be in the right section. So I'm just going to talk a little bit about kind of big picture treatment perspective. So overall models as a way of thinking about how we work with this population. And then I'm going to go into very briefly the recommended psychosocial interventions, and then pass it back over to Dr. Jacobson to talk about the medication assisted components. So I think it's important to understand whenever we're working with a population, the history of how we have worked with that population, how we have viewed their conditions, the labels that have been applied, and then the treatments that have been recommended. And for substance use or addiction, one of the reasons why this is still such a highly stigmatized a group of individuals is because of the history of how we have looked at this particular collection of symptoms. So I think it's important to understand that history, because it absolutely informs a lot of the external and internal stigma that is something that we have to consider with working with these individuals. So if we go back, and I'm just talking about United States history here, but going all the way back to really some of the earliest points in our nation and how we've treated substance use disorders, we have historically viewed it as a crime. Dr. Jacobson talked a lot about how people that are in the throes of their addiction, the intoxication withdrawal cycle, because of the things that it does to the brain, the things that it does to social networks, people will oftentimes engage in criminal behavior as a means to maintain access to the substance that they're addicted to. So we can consider some of the criminality as actually being a symptom of the condition. That's different than how we viewed addiction in and of itself. So at different points, even as recently as the war on drugs, the 1980s, 1990s, we have viewed the actual condition itself as being criminal behavior. And so the treatment focus has been to remove those people from society. So going all the way back to the 1800s, where we used to put people with substance use issues, opiates, as well as alcohol, in farms or in treatment centers that were outside of their community, and sometimes put them there for many, many years. So really the goal was that these individuals were going to somehow damage society through their substance use disorder. And so they needed to be removed from that society to protect those that were not around it. So sort of this contagion concern. So that is still with us to some degree. And the fact that we have huge numbers of individuals incarcerated for substance use related things, whether that's public intoxication or being involved, having possession, or being involved in selling substances as a means to maintain their addiction. All of those, we still have that impact today. We've also had a long history, and this has vacillated throughout time, as viewing addiction as being a moral problem or a failing. And we hear this in treatment team, even at some of the more state-of-the-art substance use programs, kind of this idea that they're lacking willpower, or they just need to be motivated before we can do anything, rather than recognizing that people are going to vacillate in terms of their motivation to make positive changes. There's going to be a lot of things psychologically that can interfere with that motivation, and that we as treatment providers can influence that and can work with that, rather than waiting for it to be something that the patient just naturally develops on their own. And this idea that people, once an addict, always an addict, and some of this comes from 12-step language, but just that people can have an addictive personality, that they can be someone who is just going to substitute one drug for another. There's really no evidence that supports any of that, that as human beings, our brain is conditioned to develop addictive patterns, whether that's to a behavior or whether that's to a drug. And so we really want to normalize and universalize that this isn't unique to that person, although they may have certain vulnerabilities that set them up for this condition. It's no different than how we would consider why somebody ends up with cancer or somebody ends up with diabetes. So we really want to be moving away from this moral idea. Later on, probably in the 20th century, was when we really started to view addiction as a disease. And there is some truth to that, and we still use that language. But I think that even that model is a little too simplistic, because it really does state that there is one process at play, and then there's one intervention or set of interventions that are going to impact, so almost a cause and effect relationship. And the reality is that addiction is a multifaceted condition or disorder. So that means that there is an element of how a person's psychology is functioning, their physiology, and their environmental contributors that are all part of the onset and the maintenance of the condition. So if we're not addressing all of those different dimensions, then our treatment plan is probably not going to be as effective, right? So really sort of shifting to the current way of viewing addiction is that this complex, multifaceted approach. So how we view what's causing, what's maintaining, and how we treat individuals with a substance use disorder and opiate use disorder is understanding that there are biological contributors, psychological and sociological, and that we need to really put together plans that address all three of these domains and all the needs that they may have. Because the development of the actual addiction condition itself, you can see, is a combination of the individual's biology, their genetic vulnerability, the environment in which the use takes place or gets modeled, or they have access to it. And then that has a dynamic relationship with the substance that they're using, how they're using it, how frequently they're using it, and then how those cause changes in their neurology. So how their brain is actually functioning is the resultant condition. So another model that's really helpful for thinking about working with this group of folks is recognizing that one course of treatment is probably not going to be sufficient, that once it's really become a severe substance use disorder, that we really want to view this as a chronic condition, much like asthma or diabetes or hypertension, that there are things that we're going to need to step up or step down for the person to help them maintain that quality of life, that we're not trying to cure the disease, we're trying to help them live as healthy and functional a life as possible. And that may or may not include sobriety. So kind of moving away from this abstinence only mindset, that there's a whole continuum of how people can achieve that health and wellness. So that should be our focus. And if we view substance use disorder, opiate use disorder, as a chronic condition, that frees us up to move away from some of the things that are stigmatizing that population. Understand that there's a heavy genetic loading that's influencing it, but there are also environmental variables, very similarly to diabetes or high blood pressure, high cholesterol, that it's the combination of the individual and then certain things going on in their environment or personal choices that we can help to mediate or change. And that medication adherence, treatment adherence, all of those things look very similar to other chronic conditions. And in fact, when we compare it to things like type 1 diabetes, relapse rates are actually a little bit better with substance abuse than they are with things like hypertension or asthma. And one of the other major things that I already mentioned that we always want to be considering in terms of the role that it plays in recovery or treatment perspectives is the role that stigma may be playing, and that we are not free from the impact of that stigma. That as treating providers, we have to be very vigilant about any biases that we may be bringing to the table and regarding the population that we're working with. Because once a patient develops that internalized stigma, it's going to result in much poorer outcomes for them. So they're less likely to seek treatment, to stay in treatment. They're much more likely to have really complicated mental or physical health outcomes, especially if there's been a significant delay in accessing care or effective care. We're more likely to see all of those psychosocial impacts, so being disenfranchised or marginalized, having issues with employment, issues with housing. If they've been criminally involved, they have a felony, even more so, right? They're even more disenfranchised from accessing the things that would be stabilizing. Oftentimes there's a lot of stigma and shame within their family system, so their social networks are really impacted. And what that results in is this learned helplessness mindset. So it's sort of that once an addict, always an addict. What's the point? What's the point in trying? Because this is just my lot in life. And we really want to be working actively against that all throughout recovery to encourage people that they can get better, that this is something you can recover from and maintain recovery from. But we have to move out of that stigma and how that's impacting. So in general, what we want to be treating, regardless of the specific interventions, is a chronic care approach, recognizing that this is a really complicated condition and not a singular disease. So there's going to most likely need to be a combination of medication, education, social support, and multiple system level structures in place. And that we're really working towards not necessarily abstinence, although that could be a goal that we're working towards, but not just remission of symptomatology. We're working towards that global improvement in health and functioning, and that people feel a sense of meaning in their life that will help them to sustain those recovery goals long term. And so when we use models like that, we see just a general reduction in use, oftentimes to abstinence, even if that wasn't the initial goal. We see increases in how they're functioning, how they're taking care of themselves, their health choices, and we see reductions in involvement in criminality or the types of behaviors that really have a dramatic cost to the individual and the community. So when we're putting together a treatment plan, we always want to be thinking, how are we addressing their physical health, their emotional health? What are the stability factors within their social network or their relationships that we want to be supporting? How are we looking at their recovery environment, the environment that they're living in or going to? And how are we helping to bolster that meaning and purpose in life? So work, volunteer, community involvement, spiritual practice, all of the things that help them to get out of bed in the morning, rather than just how do I use less, right? And knowing that that's a lifelong process. Now, in terms of psychosocial interventions, there are several interventions that have been shown to work. Big picture models, we tend to have to harm reduction and abstinence. Now, neither is necessarily superior to the other. It's just finding the right model for the individual. So recognizing that for some people, an abstinence model is going to be most effective. So that's called a cold turkey, right? Where they're really working towards abstinence as the end goal. And a lot of 12-step programming would fall under that model. For other people, a harm reduction model, or what's called the warm turkey, right? So we kind of cut back slowly to whatever level is desired for us. That's the more effective model. And then we also want to be using things like stages of change, which help us to determine where a patient is at in their process of change, so that when we apply a psychosocial intervention or a psychotherapy intervention, we're applying the right one during that time. Because as you can see, we might use motivational enhancement during pre-contemplation and contemplation, and then we're going to move into some solid CBT and relapse prevention once somebody's moved into action and maintenance. So we're not going to be providing the same intervention at a different point in somebody's care. So what's not recommended right off the bat, and what we would not use as a standalone, and so this is important when you're kind of looking at someone's treatment plan and trying to figure out if they have this as their recommended therapy, that might not be the best approach for them. So anything that's confrontational, anything that is a standalone, like mindfulness or relaxation only, or things that are unstructured as the only form of intervention, because a lot of what patients need, especially early in recovery, is skills acquisition, education, and structure. And so when we're doing the opposite of that, by providing a lot of unstructured support, we may actually inadvertently be doing the opposite of what we're wanting to do. So what is evidence-based and recommended are things like motivational interviewing and enhancement, which comes in both individual and group formats. Cognitive behavioral, which falls under the harm reduction umbrella. There's a ton of different skills that can be applied individually or in group settings. Contingency management, which is where we're reinforcing the behaviors that we want to see, and we're teaching patients how to put reinforcers into their life rather than just going without the one thing that's probably hugely reinforcing to them, which is their substance. Using things like community reinforcement approach, or craft, community reinforcement and family training. 12-step is a recommended or a program for people, but it works for who it works for. So that's not a blanket recommendation. Smart Recovery is another peer support program that is not 12-step based. So kind of encouraging people to try and find the one that works for them. Family and couples therapy is hugely recommended. And so really trying to work on those social networks whenever possible. Okay, so now I'm going to stop share and turn it back over to Dr. Jacobson.
Thanks, Dr. Lindsay. And I'll just spend a few minutes kind of going through these end slides here to talk about the medications that we have as an overview. Want to make sure leave plenty of time for your case presentation. So the FDA has approved medications, these 3 meds for opioid use disorder. It's actually 4 because the last one is also injectable. So we have methadone, which has been around by far the longest, which is our full agonist, buprenorphine, which is our partial agonist at the mu receptor, both sublingual and injectable form, and then naltrexone, which is our antagonist, which is oral and injectable, but the oral form really just for alcohol use disorder has been shown to be effective. The injectable form would be for opioid use disorder. So buprenorphine was made possible for prescription by the Data 2000 Act, which let Schedule 3 opioid be prescribed for this treatment. In 2002, the FDA approved it as a Schedule 3 opioid. And at that time, physicians were required to have an 8-hour training to get this special X number and could prescribe up to 30 in the first year and then 100. But then the CARA Act in 2016, importantly, increased to 275, the upper limit, but more importantly is when both nurse practitioners and PAs could begin prescribing buprenorphine after training. There are significant treatment barriers. There are the following barriers to psychosocial treatments. Just for the purpose of time, I'm not going to read through all of this just because I want to make sure we get to our case. But there's really a still a huge lack of providers, a big shortage across the country, and an even greater lack of behavioral health providers who have specialized training in substance use disorder treatment, in part due to stigmatization of the disease, in part due to low compensation, high turnover rate, and high burnout. And SAMHSA is advancing with their Behavioral Health of the Nation strategic plan to develop and disseminate training and education for core addiction treatment competencies, to increase the number of peer supports, and to track ways to develop ways, to track the behavioral health workforce and to fund it. Methadone has some significant treatment barriers, even though it's a very effective medication, and significant decreases in morbidity and mortality for patients with opioid use disorder when they are on methadone maintenance. It is out of the medical mainstream, and so it can be difficult for patients to access. There's the stigma that's associated with going to specialized clinics, as well as the location of these clinics. They tend to be at the outskirts of town and have very strict federal regulations and daily dosing that with COVID, the time and treatment requirement has changed, however, still is very, in general, very strict with dispensing of methadone. What are the benefits of office-based treatment with buprenorphine? It is private, confidential. It allows for continuity of care with a patient's primary provider. Doesn't require daily visits and doesn't require costly residential treatment. And so it can allow for more time for one's family and work and other activities. So in general, this has the effect of improving access to care. There is a lack of availability still. The good news is that the number of waiver providers has increased significantly. Let's look at that with the CARA Act after that, 175% increase between 2016 and 2018. And it has steadily increased more. You can see here the distribution from all counties to rural providers increasing between those years. The concerns are that many US counties still do not have a waivered provider, and particularly in rural counties. 30% of rural Americans live in counties with no waivered provider. Here you can see in blue where there's a physician and nurse practitioner or PA with waivered in buprenorphine prescription, but the white is where there are none. Many factors can influence the provider willingness to prescribe medication for opioid use disorder, spanning from having a mentor to being able to ensure financial viability of their practice, to how to approach diversion, and then ensuring mental health access for services as well. What are the prescribing changes for buprenorphine? So when HHS said that we do not have to take the 8-hour slash 24-hour course for MPPAs to obtain the waiver, it doesn't mean that the waiver requirement is gone. So we are still required to obtain the waiver from the DEA and to submit a notice of intent to obtain the X waiver before prescribing buprenorphine, but the requirements did change. So again, here the guidance is that as long as physicians, NPs, PAs, midwives have a DEA registration to apply for an X waiver, we can treat up to 30 patients without completing the training course or attesting to provision of psychosocial treatment or counseling. But these requirements have not changed for outpatient providers who will be prescribing to more than 30 patients. In that case, at this time, we still have to complete the course. And the changes, just to kind of specify what happens differently, is to treat up to 30 patients. This is the website via SAMHSA, and physicians would select other in the certification of qualifying criteria, and then enter practice guidelines for city of training, as opposed to having to enter the actual course that was taken. And then MPs and PAs would check SAMHSA's provider clinical support system, PCSS, in the certification of qualifying criteria, again, entering practice guidelines in the text box. If there's ever any need for guidance with this, we are more than happy to help. We want people to utilize this as much as possible. So sorry to kind of speed through it, but I want to make sure we have enough time for our